Last not least talk of the day. No, you haven't. You were supposed to be the first.
Sorry,
No, that's okay.
disrupted you.
No. I said it was very good.
I'll try and keep it short because you've covered most of what I was going to say. But I completely take your 4 hours, and I'm going to build on that just the one hour. I took over as national chair of SAS Charter last year, and in 1 year we managed to do 3 big things. And you know, the charter document, you may think it's not worth anything, but I certainly have used it to tremendous effect in 6 or 7 employing authorities in England, and I think you will be able to. And I'll tell you how to do it, or at least how I've done it. You've gone through all this. Numbers we've talked about. Title, the proverbial middle grade, which is even more derogatory than anything else. I'm in the middle of nothing. I'm sometimes an SHO, sometimes a consultant when I work. There isn't anybody else in the hospital when I'm providing service. And the terms and conditions of service, I just heard somebody saying that he doesn't have a job plan and it just gets taken off him ad hoc or just told to another clinic. And difficulties in progression. The biggest one is data collection for appraisal. And we gave 2 big case studies to Sir Bruce Keogh, who's the medical director of the NHS. One was mine. So, my so-called consultant, fantastic bloke, left my trust in May, sort of 2 years ago, and wasn't replaced. So all my work was under the name of a consultant who'd left the trust. And how can that be good governance? For 18 months I was working, I don't have any data. So this is what Sir Bruce Keogh has seen. The second thing he saw was an orthopedic associate specialist who did joints for 12 months. And the consultant under whose name he did it was on a sabbatical for 12 months. So, you know, when you talk about appraisal, it's a farce because my data is incorrect. I asked my trust for my data. I've done 7 operations in the whole year. I do 7 in 1 theatre session. I've done 7 in the whole year. But one of them, believe it or not, was a hip replacement. I'm an ENT surgeon. So if my data is wrong, the consultant's data is wrong. The consultant's data is wrong, the appraisal is a farce. And I've taken this up to the maximum. I've just done a big survey, and we've not released the results as yet. Only 12% of SAS doctors actually want to do Caesar. This is a craft of medicine which is getting bigger and bigger and bigger as we go on. Sadly, I didn't fit into any of the 5 groups that my friend here prescribed, because I'm not 50 as yet, touch wood. And what I am doing though is autonomous work. We've got to build on what we have, take small bits and take people like Mr. Large getting to access his offices, say, give them all access to the logbook. It's a small thing maybe, it's a big thing for me. So, the charter, the first time 4 organizations have come together. NHS employers, Academy of Medical Royal Colleges, BMA, and Health Education England, right? So what does that mean? Why do I say 4 organizations are important? Because if you take it to your trust, they cannot refuse to implement it. Because this is a document which is agreed with the government, basically. NHS employers are the people who pay my salary. And yes, it's a little flowery, because that's how we wrote it, because we didn't want it to be rude. And in it, there is recognition on different counts, and I'll cover as I go on. Minimum conditions of work, such as 1 SPA. There are 18% of SAS doctors don't even get that one SPA. Appalling. Support, development, involvement, recruitment, everything to raise our profile. A mutually agreed job plan, which is appropriate. Work compliant with working time regulation. Office accommodation and storage. Secretarial support. Access to study leave, because so many said they couldn't get study leave. Fair access to development funding. Now this is something we shouldn't lose, and if we don't access it in any way, maybe if Mamdu comes up with a way that we could all get credentials and apply to BOA, who does the credential, the GMC is not willing to pay. Can we use the development funding? We have to think, partly, anyway, we've got to get that credential. Deanery support, LNC representation, management opportunities. Now that's a big one for me. Why? I mean, I've been in my trust for 18 years, probably one of the most senior doctors there, and recognized as such, I must say. Why can't I be a manager if it has to be? All 4 organizations say, I can. So the trust cannot say that you can't. And then we did these workshops on the basis of this charter. And one of the messages we kept getting from everybody was reopen the associate specialist grade. How do we do that? We're trying. There are lots of non-standard associate specialist grades being reopened. So there is positive happening. My trust has appointed 14 associate specialists in the last 2 years. Yes, we have. And up and down the country, it is happening. It is a non-standard post currently, but the terms and conditions are like an associate specialist. And we're working with them. Again, here the consultant negotiations is what will change matters. Because if they do get a junior consultant, because that's what the government wants, then I don't think the associate specialist grade will reopen. But hopefully that won't happen. Access to e-portfolio. And here we've got to use offices of people like this. I'm going up and down the country to say, yes, we need to. Charter implementation in all trusts, training needs, formal training pathways. Mamdu and me have had this discussion many a time on how we can channelize the expertise to make it better for the NHS. And lastly, use appraisal. PDPs, we're useless at it. If you don't write something in our PDP, or if you write to get Caesar, well, next year you won't have got it, I can tell you that for sure. So you've got to take small bites, small chunks. Like he said, it's got to be a big, long-term plan. And from the workshops, this is what came out. Consultant vacancies could be offered to experienced SAS doctors. Yes, some said NHS employers, we know they're not trained, we can give them an acting up allowance for 6 months. They're safer than getting a locum. This country is paying astronomical amounts of money for locums. When you have a safe doctor, why not? What's wrong with them? Challenge the belief that SAS equals service provision. We have to, because if you want to do that Caesar, you've got to get that spine, that hand, that foot, that hip. You can't do it in one place. And pediatrics, for God's sake, it'll never be there in your hospital. You're going to have to go to another place. So how are we going to do that if we don't get that? And appropriate coding systems to record activity and outcomes. If we don't get coding, why can the HIP registry not have the GMC number belonging to you? What's wrong with it? Because you're actually doing it. And especially if the consultant's on a sabbatical, why not? And there is no obstruction to it. We've got everybody up and down the country saying it is happening. And there's a new e-referral system which has come out with the chosen book. And there is, in the drop-down menu, it says SAS Doctor. So we fought long and hard to get it. I had to go and sit in the offices of HSCIS, which is the information systems, national informational system, to get it done. So it's there. It's just gone in. The system has just come along. So come on, guys, use it. Go to your local IT fellow and say, can we develop this? And we need a national training program. This is something that has to come at a national level. Don't know when I'll get around to doing it, but it is a difficult one. These are things I fought for in the past 3 years, and we've got it. Nobody would allow us to be appraisers. I appraised 28 people last year. 9 of them were consultants. Nothing wrong with it, if you can do it. Educational supervisor. The GMC says you can be an educational supervisor. This has all come in the last 3 years. So if there's a lot of negative, please move back from the negative. He is absolutely right. Build on the positive. Build on what you have. Just stay. We can be educational supervisors. We can be clinical supervisors. We can be SAS tutors. The GMC says so. It's on their website. Nobody can argue with that. The trust ought to support us. The charter says, the charter is from NHS employers. It's telling the employers, you've got to give them management posts if they want to. I have in my trust 6 clinical leads who are SAS doctors, and they're doing amazingly well, including A&E, believe it or not. We're representing on other panels. I'm also part of the 5-year forward view, trying to develop service. And something I'm working with the GMC, that in each trust, the last 4 years, the appraisal rates of SAS doctors have been rising. Used to hover around 70%. It doesn't seem to go higher than that. So I've piloted something in the Northwest where we appointed 4 SAS doctors as appraiser leads for SAS doctors. Do you know what? 99% appraisal. So what I'm telling the GMC is there should be an SAS appraisal lead. They've agreed. Professor Stevenson, you can check with him tomorrow. He will say the same thing. It's got to happen, and we are the only ones that can change the system from within. 20,000 doctors, 20% of the secondary care medical workforce. Remember that, 20%. They're not going to fall out. They're not going to die. They're only going to get bigger because there are not enough training posts. This, I've already discussed this. I've started discussion with NHS employers to reopen the associate specialist grades. Scotland have started discussions. Employers' view is wait for the consultant contract to get sorted. We've talked a bit about credentialing. This is a formal accreditation of attainment of competencies in a defined area of practice. The GMC is doing the consultation. Please give your views. The basic thing is, when I proposed credentialing, my thought was, you go to your appraisal, you take your data from last year and say, I did 100 tonsillectomies, 1 went wrong, this is what I did with the 1 that went wrong, this is compared to the national standards, so am I okay to do a tonsillectomy? The appraiser would say yes, right? However, the GMC is not really going to give into that as good governance, so it set up the system. So an organization like BOA will have to decide on a credential, and the credential will be whatever, lower limb surgery, I don't know. And that credential will have the same curriculum that the juniors or the doctors in training have, and the BOA will be able to hand out that credential, which is GMC approved. That's what the credentialing consultation document says. Look at it. Because if we don't change anything, we have to change it ourselves now. If we don't change it and it comes on, remember, our medical workforce is getting competition from everywhere else. I was just telling somebody, I've seen an advertisement for advanced nurse practitioner, starting salary 50,000, 2 years of training. Now, the specialty doctor starts at 37,000. So the junior doctors committee and myself, we got together and said, let's apply for this. All of us. Let us see what actually happens. Do you know, a non-medical, I've taken 12 years to get to a specialty doctor status. A man does it in 2 years and gets more salary. That doesn't quite get there. So, but he is accredited because his course is accredited. So we've got to find a system of getting us accredited. And this is going to be part of that system. Have a look at it. Please go back and look at the GMC credentialing consultation. Somebody mentioned the AMRC. Yes, you're absolutely right. We can, and the words are, the responsible consultant stroke clinician will be the consultant doctor. In some cases, it may be another senior doctor, example, a specialty doctor, with the right level of competence, or another clinical healthcare professional. We got AMRCs to put this in. I have written an email which I can show you, because this document didn't have that before. So there is acceptance that we are producing the kind of work people are expecting of us. So guys, I know you came out with a lot of frustration, but there is a lot of good happening, and we've got to persuade them to keep this good going. Mamdu and me keep thinking 5 years, 10 years, 15 years, what are we going to do? And we've got to keep going. Try and get little chunks of the meat till we get to where we want to get. I told you about coding. Very important, because a patient walks in, who is the patient seeing if they're not coded appropriately? Transparency, accountability, responsibility will all come from coding. We need data. We need to take data to our appraisal which is satisfactory, not data which is cooked up. So there's advantages for patients, employers, and the doctor. And as I said, Sir Bruce Keogh has said, it will happen. And this is something that orthopedics struggles with, autonomous work. I know you struggle with it because I've dealt with 7 or 8 cases of orthopedic SAS doctors where the work gets taken off them, or somebody mentioned somebody doing waiting list somewhere else, etc., etc. I'm afraid we've got to think of the NHS as our own organization. The pot of money is very limited. Unfortunately, as has already been mentioned, there are some people who don't think like this. And sadly, that will take its toll eventually. If we want to keep the NHS, what is autonomous practice? Independent work, autonomous practice, unsupervised work. So where is the consultant when I'm operating? Last week, she was in Pakistan. Is that any help to me? Not really. Every week when I do a list, she's never in the hospital. She's in the hospital 30 miles away. Is that any help? You've got to make up your minds. My trust certainly has. So, myth 1, regulations do not allow SAS doctors to work autonomously. And I've checked with everybody. There is no legal impediment to SAS doctors working independently. There are governance mechanisms, and we'll come to that, but the GMC says you have to do it within your competencies, and you are responsible for it. Nobody can say that you cannot. They would not be indemnified. You're not covered. Is that true? No. We've checked with MPS, MDU, MDS. Everybody said that they are covered. We are covered for whatever work we do. And the ultimate line I got from them is the patient is the responsibility of the trust and ultimately the chief executive. And this responsibility can be delegated. The third one was, our terms and conditions of service say that we need consultant supervision. The pre-2008 AS model contract specifies that the AS is responsible to a consultant. This is not repeated in the 2008 contract. Accountability arrangements must be agreed as part of the job plan, but these will be on an individual basis. And NHS employers have said that at the top of the grade, SAS doctors will have acquired a high level of specialist knowledge and expertise and have the capacity and opportunity to work independently within agreed lines of responsibility. So everybody is saying we can do it. There is nobody who's saying we can't do it. All right? That is. So what's the future? We've got to get the e-portfolios. We've got to see what the associate specialist contract is, the reality. Can we expand the top of the scale? Trained doctor contracts. That's a suggestion that has been mooted. Anything in the hospital is either training or trade. And how that would work? Credential as a specialist and integrate it to the post shape of training workforce. Shape of training is a document which believes that we have too many specialists. We need more generalists. So what they're talking about is that training would be watered down to 4 years to create a general orthopedic surgeon, who then, if he wants to be a lower limb surgeon or upper limb surgeon or whatever, has to do 3 years more. I mean, I'm putting it very basic, but are we not all generalists already? We are. So how will we integrate into that? This is something which the future is looking at, 2020, 2021. So, what are you going to do with this charter? Take it to your LNC, local negotiating committee. Harness the support from the trust. Get your local dean to support it. And either adapt my charter or write another one of your own. You can do all that with your charter. Certainly in my trust, I've got coding sorted, autonomy sorted, and job planning sorted. So, and we've also got 2 extra days of leave compatible to consultants. Please, please do not call us that. We're not middle grade and we are not non-consultant career grade. And this is what I see as the future. We can do it. We can be appraisers, leaders, supervisors, managers, clinical directors, service designers, whatever we want to do. Don't be cynical about it. I know there has been lots of frustrations in the system, there still is. And I break my head every day over everything. It takes me 5 times as long to achieve something as it does anybody else. But we're getting there. Slow and steady, we'll always win the race. Why? Because we produce the work. End of. David Nicholson said 3 years ago, backbone of the NHS. I'd like us to be the brain and the heart as well. We can. That's me. Thank you very much.
Any questions?
Here.
No, I didn't have a question.
You know that?
I was just stretching.
Sorry.
And that is, I think it's completely unrealistic of the GMC who charge each one of you to register with them as the regulator, to devolve to the specialty associations for whom membership is discretionary, the responsibility to resource the development of credentialing. We can do it, of course, but we need some support. We don't have access to funds, and all of this at the end of the day takes time. Time that has to either be bought out of the NHS because the doctors, the surgeons don't have the time, and effort, and a degree of support from me and my team. So there's a fundamental disconnect in this argument somewhere.
I'd love to take your, I've already made the point.
I know you have.
And it would be beautiful if you could write back to the consultation and say exactly that.
Well, I'm going to say it tonight to Sir Terence Stevens.
Exactly. Who is going to fund this?
So is David Large.
Absolutely.
No, but we have a credential fee. So when one wants to apply for credential, submit a fee for BOA or something like that, and this would be like an assessment credential fees. But we need
There has to be
to provide a document from
Or work
registered Orthopedic Society.
But I think, yeah, okay.
Yes.
As a BOSA group ourselves, we need to sort of be a bit more robust organization in order to use our senior colleagues and bodies and associations like BMA SAS to go forward. So far, again, coming back to looking back in order to look forward, we couldn't achieve that, partly because we were hoping BOA would have been like a child, nurturing this BOSA organization and supporting us to go forward and eventually do our own running. We couldn't, but I'm very pleased that it's being picked up again. The other side of it is ourselves coming from different parts of the world. My personal opinion is to be in an association, to be organized, secretary, treasurer, this or that, to maintain the momentum, we are not possibly not as good organized as those who have been here for a while. It took me a very long time to know what is a meeting or a committee meeting, etc. But I'm very pleased that once BOA looks after this group at the moment, so we are stronger, and then we take up your issues. Because at the end of the day, suppose with all the good points that we can do, and it comes like my department, the whole admin and the whole consultant committees say, sorry, you will not, because we don't want you, because we don't need you that way services. Will I maybe able to bite back when I call the IRA? No, it's IRO. Sorry, IRO. Will the IRO call the bite back?
The BMA can't do anything if you call the IRA because
They don't exist anymore.
but yes,
Will they?
yes. I have written loads of letters on loads of issues. There have been SAS doctors who've been on the consultant rota, who've been taken off the rota. Unrealistically.
Okay, you heard him say so, huh?
Yes,
Keep his name handy.
yes. And the thing is, I want you guys to believe in you've got fantastic support. The most respected member in the SAS committee is an orthopedic associate specialist, Avani Chowdhury. I mean, the ex-president or ex-chair of the BMA SAS committee was an orthopedic associate specialist, Radhakrishna Shampal. You know, you've got the know-how, you've just got to take their skills, become one unit first, get a database. Numbers mean strength. If you have your 3,000 database and you get them to become some sort of, actually BOA offers you discounted fees as well in the early years.
But part of the problem is the membership of BOSA till now is through BOA.
Yeah.
And because of the confidentiality,
Yeah.
I was never able to have BOSA membership list from BOA, understandably. And yes, because each time we requested, Hazel Schultz says it's BOA data that they have, and not BOSA data.
I don't know,
I'm
sorry.
saying the fact of events, the emails and post letters to send a survey
That,
of membership.
I would respect that part.
Correct.
Because as an associate specialist, you wouldn't want to receive data from everybody else who
Correct.
you
So
know.
that was one drawback on our side,
Yeah.
that you couldn't get the data
Yeah,
properly. That's the reason only.
good.
Any other question?
Oh,
I'm going to be devil advocate.
go on then. I like you to be
I mean,
done.
what you said, it took us 7 years, what you said, all the orthopedic surgeons made this contract, SS contract 2008, and 7 years to negotiate, convince health education, NHS employer, AMRC, agree all these contracts, and now you have produced this wonderful SS Charter now in December.
But it took us 7 years, it took me 12 months.
No, but all
I'm
these
talking
things-
about when I came into
Okay.
it, yeah.
My question was, all these things in a vague way been mentioned in the national contract what we agreed in 2008. And now, I know you very well for that what you have been doing in BMA SAS. And with you in the last 2 years, what you have done and produced these evidence. And you have educated all the NHS chief executive and all these associations that this is the requirement. Can you tell me with your experience and vision, how long you will need to educate the SS doctor? Maybe it's not 19,000, it's not the other 19,000. My study observation, all the paper is in the range of 50 to 60,000.
But
Because I heard from these
My
15
answer-
enthusiastic doctors,
my answer-
most of them
Yeah.
said, I don't know this exists. So how long will it take? Tell me.
my answer is, I only have 2 years to do it. Because when I turn 50, I'm going to stop.
I think you said that you are young and you are going to work, so you are not interested.
I have 2 years, that's why I go out. You know, last weekend, Saturday, I went and spoke to, when I got the invite, it was the BASH conference in Warwick, University of Warwick. And when I heard it, I said, that sounds like a good one. So I said, yes, I'll come. Do you know what BASH stands for? British Association of Sexual Health. ENT surgeon, me. Right? Do you know how many SAS doctors were there? 210.
Exactly. That's what
Fantastic. And they are such a, they have a subsidized conference of their own, subsidized by the parent body. So they pay £200 for 2 days. Good structured education, and that's what you need to do.
Good food.
So I don't know about food, I didn't stay for dinner.
Any other question? Yes,
No,
Abbas.
it's all been happening. And
Abbas, Salam. Abbas.
I'm telling you, I've been watching from the back row, and the reason I sat in the back row was for a good reason. This is the first time I've come here. And what I see in front of me are some very senior people who've been associate specialists for a very long time, and who have contributed immensely, surgically and clinically, and educationally, and rest of the ways. And then I thought we were the only one group who was suffering because we were kind of a corner of the country where the light doesn't shine, which is a fact when you go out and speak to other people. But over the days, I found that most of us suffering from the same malady, same disease, almost similar signs and symptoms. Some of us are a bit more positive, some of us are a bit less positive, or could be negative. And I agree with, and I thank you for doing this presentation, because it does give us a bit of a support when we go and speak to our management. The problem we had, I'm talking about, I can only speak on my trust, in our trust, the problem is, for good or bad, it's not the actual manager. The problem is a consultant, and I'm saying, I'm not mincing my words. The managers are not a problem. I have spoken to them a number of times, and they are very supportive of what we do. The problem is a consultant. A person doing everything normally, suddenly downgrading and all that, and now things have come far worse. What I would like you to do kindly is to send us by email the presentation, the one you have just done.
Mm-hmm.
Because in the next 6 weeks, we are actually having to sit across to our consultant body, with the managers and HR on the sidelines, negotiating our contract, and we are not given a chance to negotiate or be told about our next job role. It's not a job planning. And we don't have much time there. We're really lacking. So if we have this on the back, I say these are the things.
Yeah.
These are nationally recognizable conditions.
We have it for BOSA, then we
Yes, it's called the BOSA presentation, so you can
Okay,
have
so
it.
when we have it, we will have it,
Yeah.
and then
Yeah.
for everyone to. Any other questions?
No, can I make a comment on that? I don't think it's right to say the consultant. I think most of consultants helping us as doctor and are very supportive, maybe some minority, but we cannot just throw blanket and say the consultant. I disagree with
No,
this.
I'm not saying about consultant
It might
as
be
a country.
a problem in department visa, but I think all the consultants support us as doctor. They just need to create the environment and need what we need. I don't like to have a confrontation between body, the consultant, the problem, pointing finger. We need to work with the team. Even if someone you think is a difficult consultant, we can win the consultant on our side. I don't like this approach that, well, they're consultant, we need this one from the top. No, we are the team. We need to work as professionals in the team and win these people. And I'm telling you out of my heart, the majority, 98%, are supporting you because we do the work together, doing the job together. So I don't like it. You might have a problem, someone person, but I disagree with this statement.
No,
Sorry.
I'm not talking about
Mr.
consultant
Stanley,
in general,
okay.
no.
Can we-
Stanley.
okay, Mr. Stanley.
I think some of the difficulty in relationship to what you've just mentioned comes down to the changing face of the NHS. For example, in Sheffield, there was an email that went round fairly recently pointing out that there would be no further approval of annual leave for consultants for the time being because we were too far behind with our 18-week target. Now that doesn't actually achieve anything, it just irritated everyone. And so when you actually come down to, when it comes down to job planning, particularly for SAS doctors I would suggest, if you have a series of consultants in place with subspecialty interests, then when it comes down to working out how the 18-week target is going to be met, the 18-week target will be determined by what is the biggest bulge that currently exists. That may change in 6 months' time. So who is it that is best able to fill that slot? It may well be that it is an SAS doctor because of the fact that they've perhaps been doing some footwork, although they may have been doing other things as well. But for the time being, it's more difficult to change a consultant's special interest when they've been doing that only, or pretty much only, for a number of years. So I think there are difficulties achieving what you would all like, because it just is hard at the moment within the NHS.
His point is very valid. And if you add to that, the government wanting to take 24/7 working and 7-day working and all that, elective work on weekends and stuff like that, they cannot achieve it. Even the consultants will not be able to do it. It is just impossible. They're going to take away Schedule 3, Para 6. They wouldn't even want to do it. So we have to produce that work as medical workforce. So the better the terms and conditions that you are with your team, the quicker you will produce that. And that recognition will come, irrespective. So don't expect that you'll be asked to do all Saturdays, but they will have to ask you to share Saturdays, because everybody will have to work Saturdays. That's what the government wants. Rid of Schedule 3, Para 6, which is they want elective work up to 10 p.m. at night, 6 days a week. So premium time will be only after 10 p.m. till 7 a.m. and on Sundays.
So will that be working time directive?
Well, that's what they're saying. They're going to impose it if we don't negotiate. So we're negotiating now, and we will. So what I'm trying to say is, Mamdou is right. Don't adopt a pathway of confrontation. Chip away. And we've done it in the past, and we've got success. We will win eventually.
Okay, we'll do two more questions.
So
Because Mr. Stanley will have to sum it up for us. Okay.
I think in every different places we have to go on an individual basis. For me, my consultant has been quite supportive to me. Yes, I have been asked to go out of theatre to do clinics, but they also understand the sacrifices made, and they are able to help me in certain aspect. For example, for reference for the exam, sometimes when I'm asking for the last minute study week, for like today, I kind of messed up that it was for tomorrow presentation. Today my clinic, one of the consultants has actually doing my clinic.
Excellent.
So you always have support. This is a team.
Yes.
There is no point in keeping on explaining about all the negative aspects. I would disagree that the CSR route is actually difficult, because if you look at how a trainee is coming from the medical school, getting into the training scheme, going through the 7 years, it's actually much harder. Now, I couldn't get into the training scheme in 2008, 2005 when the MTAS came. So that's the reason I ended up in the SAS route, not because I wanted to go there, because there was not much option, because the training route is far difficult. And even if you're a trainee or coming out of it, trying to go into the consultant route, it's even harder. It takes almost 10-15 years for them to achieve the same balance, even if you're going through this route. And that's what is happening. So I would disagree in a way that we are being sidelined or anything like that. Obviously, because the only difficulty is we are unable to rotate in different places, which is what the training is gathering.
Which is precisely what we're saying.
Yeah.
So, but there's a lot of frustration, which is there, but we're moving forward from it.
Yeah.
We have to bring the positives in, and we've got to use people's offices to try and implement. So, like you said, there are certain.
We have to find the positive.
Exactly. We're not asking to become consultants. We're not asking to become sub-consultants. We're asking to be SAS doctors.
I would add one more R.
Is clear.
Yeah, I would add one more R along with the recognition of things. We have to be more proactive in research. The only way that we will be taking importance is we are not just doctors. We are in a way scientists. We are slightly above the average people. So for us to make ourselves a bit more pronounced is we have to do our own publication.
Thank you. Okay. Mr. Stanley will just sum it up. We want to go.
Sorry.
Thank you very much.
We have a meeting with CQC.
Thank you. Thank you.
Thank you.
Thank you.
This will only be a couple of minutes, really, I guess, to sum up. I have to say that for me, having been with you all day, I've really enjoyed myself. It's been interesting, both the presentations that were made this morning. It's been very interesting to hear your comments. And I've also been very pleased as well to hear what Mike said. Mike Kimmons has said to you that the BOA is interested. He has said that that is not an interest that's just sprung up, because it does go back several years, and I know that from personal experience as secretary. I am also aware that in my time being involved with the BOAM Council, it was so difficult to know who we were trying to approach. And as I mentioned earlier, I do think that when there are only 15 of you in the room and there are 3,000 SAS, there's something wrong.
Yeah.
And you need to try and do something about that. And that will make a big difference as well. Numbers speak powerfully when you're in discussions with people. So I do think you need to look at that and see how you can move that forward. I mean, David pointed out how hard he is. He looks fairly hard, doesn't he, actually? but that is to do with standards. It's not to do with any individual dislike of an individual person. It is to try and find a honest, fair way. He would have to explain how it is that someone gets onto the register who then causes injury or death. So it's not individual, it's the reality of life that you have to meet those standards. And I hope that you would feel comfortable approaching him. You know, we are all approachable. And in many ways, I think you've almost been preaching to the converted, in that people do appreciate. We have 2 SAS doctors in Sheffield. Yes, they have been moved around, but that's been really directed to the needs of the service. But they do operating lists independently. In Sheffield, we don't have any trauma list that's not consulted in theatre done, even if it's with a trainee of experience. So we actually don't have, it's one of the things we insist on, that the consultants are in theatre, they're not in their room, they're in theatre, they're not in the coffee room, they're in theatre. That may be different to lots of other places, but that's one of the things that we've insisted on. So I'm sure he would be happy if there was a need for you to approach him and to comment on that. I've just recently finished as chairman of the Intercollegiate Exam Board, and again, it's to do with standards. In the exam, it's fairly easy. It's not to a certain extent the judgment thing. If you get the mark, you pass. If you get one less than the mark, you fail. Full stop. The computer works it out. So at the end of the day, it's an assessment of knowledge and skills as best we can. And I've mentioned already that same principle will go through Europe and probably through the rest of the world with time. But one of the most interesting things I think we've heard is what we've heard from the BMA, to be honest. You know, when you look at the problems that you face and you think they are not achievable, we've heard just now that I thought it was 3 years, but then he changed it to 1 year, what he'd achieved. Dr. Kochhar had achieved in 1 year. I don't know if it's 1 year or 3 years, or whether the culmination has been the last year, but it's been progressing over a number of years. If you take that on board, then the 15 or so of you here could change significantly the orthopaedic perspective and achievements that you could make over, say, 3 years, something like that. So I guess in summary, I would like to congratulate you for being here. I feel that it's been a worthwhile exercise for me to hear what's been going on. I've enjoyed myself, and I'm sure that you have got through to the SAC chairman and the BOA and the BMA although the BMA perhaps were helpful to yourself. I'm going to say I wish you well in your future development. I have one other job to do, which was really to just tell you who I thought did the best presentation, podium presentation, and the best poster. It was judged by a lot of us, actually just me, so it is a personal view, I'm afraid. And I have to say that I thought that the best podium presentation was by Rajaj. I gave you that. I said, because I thought I ought to say specifically for which presentation, and I chose the metal debris from Trunnion-ware. That's what I gave it to you for. I thought it generated a lot of discussion from people, and that is one of the good things when you present something. I think all of the presentations that I heard perhaps weren't the most scientific, and I think that could be improved. But I thought that you actually had tried to do something, and you gave us a very long, detailed account of what's happening in stem cells as well from the literature. So the amount of work you put into this meeting, I thought, was worthy of your being successful. And then the best poster I put to Mr. Gupta. So I chose that one, the MPFL Reconstruction for Instability, it's some nice illustrations you had on your poster. And you did struggle getting it up to stay up as well. So for me, it's been a privilege to be with you. I hope that you've all had an opportunity to hear what is being done for you. But I would say it still comes back to you generating the energy to actually change things as well. So I think it really does come down to you. And you have to get something done about numbers, really. And then Mike will let you have 2 days if you want at the BOA. I'm sure that it will be possible. And it is, you know, if the numbers are there, it can happen. To be honest, it's not anything against anyone at all. So thank you on behalf of everyone, and I wish you all well in your future careers as you progress.
Thank you.
And just to encourage you, the orthopedic consultant chef would only get one SPA as well, which is outrageous, I know. But all you consultants in SPA. Good. Thank you very much.
Walking to your hotel.
Not yet, there will be. I just have to agree with Rescue Chair, Professor Malaranga, if you know him. Right, so we want to, then once we've got that agreed with Rescue Chair, we'll advertise through to the BOA. Yeah. So you'll get it in one of those newsletters. Yeah. And then we always hear, as you said. Yeah, and how you would contribute. Yeah. Because I think that's important. But yeah, I think we must do that. Come around. Okay. Yeah.
Is it all need to do? No.
Pretty useful, I would think. And we have got 2 years to use it.
Ask him tomorrow.
It expires in 2 years.
He's coming to one of the session, okay?
Yeah. Thank you very much.
Nice to meet you.
Have a nice evening.
Not a single fellow. All consultants automatically fellows.
Right. Okay.
You need to be here for a minute, please.
Can I?
Yeah, please. No, you need. No. Please can. He wants to set up this.
Can everybody come up for a group picture, please? Mandur?
Huh? Oh, they want a group
Tell me it
picture.
was a picture, okay.